join பண்றேன்னு இருக்காங்க.
Okay, madam.
Okay, we'll start. Then only we can finish properly. I will start first and then madam will join.
Okay, madam.
Okay.
So, on behalf of the Obstetric and Gynecological Society of Southern India, Clinical Skills Hour on CTG, Labor Care Guide and Partogram, we would like to give a warm welcome to all the faculties and also the moderators, Dr. Jayashree Gajraj madam and Dr. Deepa Thangamani madam. We do invite on behalf of our President Sampath Kumari madam, myself, Dr. Meena, Secretary, and Dr. Meenakshi Sundaram, Treasurer. And we have interesting panelists from Dr. Shafreen Banu, PG, MGM Hospital, Dr. Arutra, PG, MGM Hospital, Dr. Pavna, PG, Apollo First Med Hospital, and Dr. Nandini, PG, Apollo Vanagaram. So I request Dr. Deepa madam to take over the session. Already the case is being posted in the group, students and mentor group. Thank you, madam.
Yeah, thank you. No, I'm not posted anything. This is the case discussion. Yeah.
Welcome, Vijay Sheshadri madam. Good evening, madam. We have
Welcome,
senior
madam.
faculties also present here, apart from students, madam.
Okay.
So
Thank
Rani
you.
madam is there, Umara madam is there, Dr. Sujata Charles, Dr. Rani Varadaraju.
Yeah.
Over to you, madam, to start the session.
Thank you.
This
So
is the
first,
last month session. As we couldn't take the last month session, which fell on our clinical meeting, we are proceeding for the session today, this month.
yeah, thank you. So we proceeding, that is a short presentation of LCG I will do, then followed by the LCG case discussions. Then we will go with the CTG case discussion by MGM team. LCG will be with Vanagaram Apollo Hospital as well as PGs from Apollo First Med Hospital. So we all know why we have moved on to the labor care guide. Pavana and Nandini, we all know as so the questions will be suited to you. I think better if you are having your videos open, that will be better for others to listen. My video is open or not, I'm not sure. Okay. No, my video is open. Okay, so the LCGs, we will be doing the labor care produce a new Partograms. We will be doing it in active phase of first stage of labor, which is 5 centimeters or more. It is irrespective of the parity, whether it is a multigravida or nulli gravida, whether membrane status is intact or not. We will be having a LCG Partograms. In LCG, there is labor latent phase monitor can be done separately. The same thing for all high-risk cases that need an additional monitoring. Whether you are in a primary care, secondary care or tertiary care settings, we can follow the LCG. Okay, so the main difference between the old Partogram and the new LCG is in old Partogram, it is actually time driven. So what is, we have an alert line and an action line which depends upon the vaginal findings, like whether the progress of the labors, we have an alert and action line which is a time driven. Here there is not a time driven, it is overall assessment. We have totally 7 sections. So the first section will be like identifying the information to share decisions. The second, third, fourth, fifth sessions we have alert points. So that is each and every, even in a supportive care, even during the care of the baby, care of the woman, labor progress, we have an alert criteria. So we are not only looking into the labor progress, we are seeing as a whole. So each alert point at each times we will be acting on it. This is how the WHO labor care guide will be. Okay, so initial information, as session by session, I will be discussing. Here we'll be having a time, and section 1, you have all the informations, and then the section 2 is supportive care, where you have a companion, pain relief, oral fluid and postures, posture of the patients, and section 3 deals on the care of the baby, and the care of the woman is section 4. We have, these are the alert criteria which falls on. So whenever someone is falling on an alert criteria, we will be then and there we will be treating them rather than only concentrating on the labor progress. So as a whole, we will be treating the patient. So each stage you have to assess a record and check plan. and check the alert reference and plan accordingly. So what are the alert columns? We will be seeing one by one the alert columns. So these are the alert columns. It is on the vertical columns. It will be staying here. So these alert columns contain a reference point for supportive care. Suppose if there is no companion, we will be putting as N and we will be putting the red. So in the end, you have to action plan, you have to give a companion. If the patient have a pain and there is no painkiller has been given, then it comes under N. Then it is again a L alert. So like that, each and every column will be discussing. Whenever you have experience an alert, you have to follow your local protocols, whatever the local protocol, whether if the patient, if the contraction is over hyperstimulated, go. If the temperature is like patient's temperature is more than 37, give para, do the investigations as per the local protocol, give an antibiotics. If there is a PROM, give a local, go on, see your local protocol, go on, give a antibiotics. Like, so section 1, we have a full record. The first is name and then parity, then labor onset, whether it's a spontaneous. Active labor diagnosis, it is not the patient admission timing, it is the active labor diagnosis at what date, what time, and ruptured membrane has to be notified here. Is there any risk factors like obstetric risk factors, medical risk factors, or previous history of any kind of stillbirths, diabetes, hypertension, PROM, we have to mention here. So next section is a time axis. So time axis, it's mentioned here time, and this below it's a hours passed. So how many hours? So at the end of this is the timing. You will be noting all the we will be plotting all the sections, and this is at the end of 1 hour. What is 1 hour passed since you notice the timing? So this is a 2 hours. The 7 o'clock you're mentioning, at 8 o'clock it's like 2 hours has been passed. So this is how. So you have either 12 hours format or 24 hours formats. And the second stage you have 3 hours. Why the second stage is 3 hours, Pavna? Pavna, why the second stage is 3 hours?
Ma'am, for primary second stage, delivery should be done within 3 hours, ma'am.
Yeah.
And
For a multi?
for multi, it is within 2 hours, ma'am.
Okay. So with epidural? Without epidural?
With epidural, 3 hours, ma'am. Without, it is 2 hours.
Okay, so that is the reason. So whatever the patients, most of the time the second shift should not go beyond 3 hours. We have a separate pushing columns. So how many hours the active pushing, active second stage has been dealt in separately. Here in the same LCG we will be having. Section 2, we have a supportive cast. This is a companion. If it comes under N, you have to offer a companion pain relief. If the patient has a pain and you have not, patient declines, you have to tell, we have to assess why the patient declines. And if there is a painkiller, the patient is, you are not giving any pain management, then you have to offer. These are the pain management you can do from relaxation techniques to OPS to epidural, depending upon your local protocols. Oral fluids, you have to encourage. If there is not, patient has not taken oral fluids, you encourage a light diet. Posture, most of the times the patient should be mobile, lateral, kneeling or standing or walking. So in the second stage, you can consider the patient as a lateral, squatting, kneeling and standing positions. Even in the second stage, if the patient is in supine position, it comes under the alert column. So first stage, that is in the first stage of active labor. What is the first stage of active labor, Nandini? How many hours? From which dilatations?
5 centimeter dilation
To?
to 10 centimeters dilation.
So fully dilated. So second stage from fully dilated to?
To delivery of the baby.
Okay. So section 3 is care of the baby. Care of the baby, we have 3 parameters. Baseline fetal heart rate. So whether you do a continuous monitoring or you do intermittent auscultation in the first stage, Pavnam? So it depends upon that. When do you decide the continuous monitoring of the continuous CTG monitoring is needed in this first active phase of first stage? So if it is a 5 centimeters, you have to decide whether continuous CTG monitoring is needed or you can go for intermittent monitoring. So what criteria you'll do a continuous monitoring? Okay. So
If any risk factors are there.
any risk factors
Yeah.
are there.
Alert lines are yes.
Okay. Any risk factors either in the antepartum period or so all the high risk mothers, the chat box among students, all the high risk mothers will be giving a so antepartum high risk mothers like hypertensive mother, preeclampsia or diabetes on induction of labors, intrapartum risk factors like ruptured membranes, or you are starting epidural, you are giving an oxytocin injections, probably you will be doing continuous monitoring. Okay. So scare of the baby, you will be either do an auscultations. If it is a low risk mothers, is a high risk mothers, you will be having a continuous. If you are putting a continuous CTGs, how often you will assess? The same. So every 1 hour anyway, the CTG has to be assessed by the registrar, signed and documented the CTG stickers. And in the first stage, every 30 minutes has to be plotted in the LCG.
LCG.
Okay. LCG. So what are the things you will be plotting? Your baby's heartbeat as well as the heartbeat. How will you do the plotting? If you're doing intermittent auscultation.
There are 2 boxes in that LCG, ma'am. So every
Yes, 2 boxes. So every 30 minutes in the first stage and here every 15 minutes in the
every 15 minutes.
stage. Every 15 minutes in the second stage. So one is like fetal heart rate you will be documenting. The other is any decelerations is there or not. Okay, how will you do a fetal heart rate if you are doing an intermittent auscultation? After each contractions for exactly 1 minute you have to do an intermittent auscultation with handheld Doppler or stethoscope. So then you will be monitoring or then we will be documenting what are the heartbeat here, and post contraction is there, and since you are monitoring after the contractions, is there any decelerations, you will be mentioning as late deceleration. Why here it is variable deceleration has been mentioned here. So variable deceleration, will you see, will you able to hear in intermittent auscultations?
No, ma'am.
No.
Okay. So after the contraction, if the deceleration is there, it is late deceleration. So it is marked as L. So variable deceleration, if you are doing a continuous CTG monitoring, you can notice a variable deceleration and put it as V. If variable deceleration is an alert signal in LCG or not? Only L.
L. No.
L, ma'am. Only late deceleration.
Late decelerations. Okay. So late deceleration is alert signal. Okay. So if it is a prolonged or late, turn to one side and escalate. Okay. And do a protocols. What you do, you have to do all your drills, interpartum resuscitations and escalate. Okay. Then you will be seeing a color of the liquor, fetal positions, caput and molding. So can someone tell what is molding? What is molding?
Ma'am, if the sutures oppose each other, it is molding, ma'am. And
Okay.
as more the sutures overlap, the plus and plus we will put, ma'am, in LCG.
Okay, that is what. So if it is a 3 plus, it is an alert. 3 plus caput is an alert, and occipit post anterior is not an alert. Only posterior and transverse. Okay, whether it is a left occipit posterior, left occipit transfer, right occipit posterior, or right occipit transverse, P and T. It's only the posterior position of the baby head on transverse position is an alert met. Okay. So the same thing for the woman. They have the pulse, systolic BP and diastolic BP. Diastolic BP more than 90 is in red, and systolic BP more than 140 and systolic BP less than 80. Temperatures as well as urine. How often you will do a urine testing in LCG?
Every 4 hours, ma'am.
Okay, what do you look for the in the urine examination?
Acetone.
Proteins and acetones, ma'am.
Okay. So if there is an acetone 2 plus means what does it means?
mother is dehydrated, ma'am.
Okay. So most common is dehydration is prolonged labor. Okay. Fine. So that is an alert. So if it is a dehydrated, you will correct the dehydrations. Then column section 5 contains contractions as well as the duration of contractions and the cervical dilatations and descent. How will you do a descent part here? What is this? 1, 2, 3, 4, 5 and LCG? What does it means?
1/5 palpable in the abdominal examination we will see, ma'am. Not
Yeah, it is not a vaginal examination we are plotting in LCG. It is only a abdominal examinations. Okay, so 1/5, 2/5, 3/5, and 4/5 and 5/5 palpable per abdomen. So dilatations and contractions. So if there is a contraction is less than 2 centimeters, less than 2 contractions, and the dilatation is like 6 centimeter. So what do you do? Less than
There
2
is no
contraction is an inadequate contractions.
inadequate contractions, ma'am, and the cervix is dilated to 6 centimeters, so we can wait and watch, ma'am, for spontaneous progression.
Okay. Suppose if it is a 6 centimeters and for a longer times like 4 hours and
Then
the contraction is less than 2 contractions.
we can
Accelerate
augment
the
Alert
labor,
ma'am.
augment with the oxytocin.
So that though there is one alert is met because the contraction is inadequate, though it's 6 centimeters at more than 5 hours only, then alert in cervical dilatations, we can bypass the next examinations and we will be increasing by augment the labor by doing an artificial rupture, or you can start an oxytocin. Okay. So if there is more than 5 contractions, like 6 contraction in 10 minutes, then
If
it is a
oxytocin is going
hyperventilation.
on, we will stop, or we can give tocolytics, ma'am.
Okay, so to stop the contractions. Okay, so we'll see the fetal heart rate, and then if it is continuously observed, it's another continuously, it's more than hypercontractions, then we will be, even though there is no fetal heart changes, we will be giving a tocolytics. If syntocinon is there, it will stop it and see whether. So this is a dilatation. It is there. Second stage we have already discussed. And descent is varies from person to persons. Only the abdominal palpations we have been mentioned in the plotting in LCG. So first stage is fourth hourly. Second stage depends upon the pushing or baby well-being. We will be doing a assessment. Section C6 is medications, which whether you have given whatever the medication has to be documented. And every 4 hours assessments we have to see the plan. If it is a normal progress assessment, then we will be continuing the care. If there is any delay, like the contraction is less, or if there is a temperature, or if there is a more hypercontraction, or duration, if the contraction is 3 contraction, but duration of each contraction is less than 20 minutes, 20 seconds, then we will be augmenting the labor. We won't be waiting for the cervical dilatation criteria. So even as and when the alert guideline met, we will be augmenting. So with this, we will go to the first case. Pavna, this is a 24 years old primey, 38 weeks, low risk, complaining of on and off pains. In labor rooms, there's a reassessment of the mom and fetus done. It is a low risk. Abdominal examination, uterus corresponding to dates, contractions, one contraction lasting for 15 seconds. Fetal heart is 140 beats per minute, head 4/5 palpable. Will you do vaginal examination?
Yes, ma'am.
Why you do vaginal examination? There is
To
no
know
contractions.
the progression, and contraction is only one contraction, and to know the progression, ma'am, basically.
Sorry. Okay, you have done a vaginal examination. Cervix is 3.5 centimeters long, soft posterior, os closed, head at -3 stations. What do you do? Is she on latent phase of labor?
Yes, she is in latent stage, ma'am, but she is not yet entered into
Hello?
active stage of labor.
Okay, so
Hello?
will you admit her?
Can observe her, can keep her for observation, ma'am.
Why you want observations? You said
நான் ஒரு
this is
ஆன்லைன்ல
latent phase
இருக்கேன்.
labor.
இருக்க சொல்லுங்க பாக்குறேன்.
Okay. Okay.
வெயிட் பண்ண சொல்லுங்க. அங்கதானே
Kanan,
காருள்ள தானே இருக்காங்க.
Sri, once can we mute people?
yes. Okay. Hey, So vaginal examination done. She is not in labor and there is a contraction. So you will be, you said what is latent phase of labor? When do you
there is
diagnose labor first of all?
when there is strong pain and contraction, it starts, ma'am.
When there is an inadequate contraction, slow progress, and the cervix is not yet dilated, it's only less than 5 centimeter.
No, that is, I'm not asking what is the diagnosis of labor? When do you diagnose labor?
When there is strong, when the mother is feeling pain, ma'am, when the pain begins, when there's strong contractions.
Okay. So when there is an persistent contractions, regular contraction is getting regular contraction with a cervical effacement, you diagnose as a labor. So this is you have to observe her. Then only we know whether she is whether she is in labor or not. So right now she is not in labor. Okay. So but you are in a dilemma. So that is the reason you need to observe her whether she is in labor or not. Okay, so observation, how long you will do? Maybe 4 hours. So reassess her whether the contraction is there or not. If the contraction is not there and there is no progress, then we will be sending her home. Okay, so latent phase is only when there is effacement as well as a good uterine contraction, like partially effaced, like 50%, 25%, and there is a signs of dilatations and there is a signs of some kind of show or some kind of mucus discharge, then you will be diagnosed. So what do you do in latent phase? Is there any criteria for latent phase? Will you put LCG for latent phase?
Can put, ma'am.
Can put. There is no LCG, there is
No
no
LCG by WHO, but
WHO doesn't have, but you will be following your unit protocols, local protocols to do monitor the latent phase. Okay. So
The
latent
primary aim of introducing LCG itself was to do away with that fallacy. Okay. Because
okay.
we have earlier partograms, we were plotting right from the beginning. So that is the whole idea of the LCG. So that intensive monitoring is done once the she crosses and goes into the active phase. So, yeah, sorry, go ahead.
Okay, so that is what diagnosis.
Ma'am,
of
one
latent-
doubt, is there any role for anybody to have a intensive monitoring in latent phase? Is there like some point in pregnancy where we'll say no, this patient may need even latent phase? Is there something like that? I mean, apart from the labor care guidelines.
It is an individual protocol.
It's an
Priya.
individual thing, no? Individual patient, if you feel needs to be monitored, only thing you will not plot it on that LCG, that's all. You will still monitor.
Like a severe heart disease, severe anemia, or
Absolutely.
yes, ma'am.
She automatically comes into a different category, isn't it?
Yes, ma'am. Yes.
So like diabetes may not be the low risk patients. Diabetic patients will do little bit of it. Suppose if the latent phase you are admitting in the hospital every 4 hours or 6 hours you are assessing. For a diabetic, we will be doing a vitals little early. That is the only difference. And all your induction induction of labor patients, once they've gone into the labor, that comes into the latent phase. Okay. Suppose they are coming with a ruptured membranes. Once they establish labors that the contraction starts, they come into the latent phase, but they are high risk. So you need an intensive monitoring. So that is the difference between with membranes, without membrane. Okay, so the confirm the labor, rule out false labors before you diagnose the mother is a labor. If it is a low risk, observe her and send her home. If you diagnose a labor, then admit her. Like up to less than 4 centimeters or 5 centimeters is still a fully dead phase. 5 centimeters is still a latent phase. Latent phase, how long it will last for the primary and how long it lasts for the multi?
Primary 18 hours, ma'am.
Okay.
And multi 12 hours.
10 to 12 hours. Okay. So these are the observations, membrane status intact or not, rupture membranes, note the time of rupture. These are the PROM. When you do an expert management, they are still coming to the intensive monitoring during this period. Okay. So what do you do in the latent phase? What, so you admitted, if the patient is in latent phase, what are the parameters? How often you check her vitals? See, it's out of the questions LCG, but I'm still asking you. Because as a whole, you have to know, diagnose the patients and what to do in the latent phase. So they have to be monitored. How often will you do it?
Every 4 hours.
Okay. Low risk mothers every 4 hours. What are the things you will do in 4 hours? Okay, just the vitals, BP, heart rate, temperature, like how your maternity
We'll see the fetal heart rate.
And fetal heart rate every. If it is a low risk mothers, you do intermittent auscultations every hour or every 4 hours or every would depend upon. These are all the labor care. The latent phase is totally up to your intermittent, but you have to do a intensive monitoring if they have if they are a high risk woman. Okay, so basically we have to ask the patient to move around, do the position change, walk around, be with the family. If they have a pain management like false pain, irritable pains, you give some kind of paracetamol, warm compress, breathing supports, all those things you have to do it in the latent phase. And pain management, whenever the patient complaining of pain, strong pains, look for the contraction and do whether she is gone into the active labors. That time you have to do a vaginal examination. Otherwise, if the contraction is regular, like every 3 contraction in 10 minutes, and then after 4 to 6 hours, then you do a vaginal examination to confirm whether she is progressing or not. Okay, when she complaining of strong pains, asking for pain relief, do a vaginal examination to see what it is, whether she is in active labor or. Okay, fine. Okay, so latent phase is like not necessarily for 5 centimeters. You will be doing a LCG. Latent phase, suppose if she is ruptured her membrane, if 2 centimeter, if she is having a meconium stain like and whether which is a multigravida planning for normal delivery, then you need to do a continuous CTG even if it is indicated. Okay. During a CTG, if the baby's heartbeat is tachycardia, you will continue do the continuous CTGs. So even if it is not in active phase, do not leave the mother if she has a high risk factors. Like Dr. Priya Kanappan asked the questions, what to do if it is a high risk woman. Okay, so if indicated, you have to shift all your monitoring for the baby and mother very often or continuous if needed. Okay. So with this, we'll go on to the case 2. For 39 weeks, spontaneous labor, low risk, admitted at 2 p.m. Vitals normal, fetal heart normals, uterus is corresponding to dates, 2 contraction in 20 seconds, cervix bella phase 2 centimeter, mid position, head at -2 station. Is she in latent phase or she is in false labor? Hello? She is in latent phase.
Latent phase.
She's latent phase, ma'am.
Okay. So will you plot LCG or will you monitor?
We'll monitor, ma'am.
You will monitor. Okay. So whatever we have discussed so far, we will be doing a maternal monitoring, baby monitoring, intermittent auscultation if she is a low risk, or high risk, we do an admission CTG followed by frequent monitoring depending upon the local protocol. So at 4 p.m., her contraction is increased. She is 5 centimeter dilated since vertex is -1, bag of membrane, pelvis adequate. So what do you do now?
So LCG can be plotted, ma'am. She's in active stage of labor.
Okay, so you will plot an LCG. This LCG has been put it like this. G1 spontaneous active labor diagnosed at 2 p.m. So is it correct or not?
No, ma'am. It's at 4 p.m.
It's 4 p.m. Okay, so you for and then ruptured membrane they mentioned at 6 p.m. No, maybe I don't know. Okay, it's a wrong information. What they have mentioned is wrong. Accept. So whatever the information has to be properly because this is the documentations. Okay, so what do you do now? See, 5 centimeter dilator, -1 station, bag of membrane is there. Will you do acceleration or you will continue the monitoring?
Continue the monitoring, ma'am.
4 hours.
Okay. ARM or oxytocin? Anyone do ARM or oxytocin?
No, ma'am, there's adequate
We can
contractions.
wait.
No need to do.
Okay, so there is an adequate contractions. Okay, three to 4 contractions and duration of each contraction is 30 seconds.
30 seconds.
Okay, so this is how the LCG is put it at 4 p.m. That is 16 hours. It is normally mentioned as 2 p.m. as 16 hours. Okay, So what is section 2? Companion. Yes. Patient is mobilized. Pain para 1 gram has been given. She has given taking adequate oral fluid. So all the supportive care is fine. And section 2 is fetal heart rate, amniotic fluid intact, 5 centimeter dilated. Position is like not mentioned anywhere in the positions. So we have put it as a blank in the position point. No carpet, no molding. So intact membranes and then no decelerations. Heartbeat every 30 minutes. Heartbeat is man. So will you do continuous monitoring or here intermittent auscultations?
Intermittent task.
Intermittent.
Why intermittent?
There is
Because
low risk and there is
She doesn't have any low any risk factors. She came in latent phase and progressed quickly within 2 hours into the active labors. How did you why do you do the PV? Because he asked for the pain management. That is why you did a PV within 2 hours. Okay. Then maternal monitoring is fine and contractions 3 to 4 contractions here mentioned is 2 but 3 to 4 contraction 30 seconds. Dilatation is 5 centimeters, which is put it as a cross, and 4/5 palpable, put it as a circle. Section 6, she has a pain para 1 gram has been given. On oxytocin, no, and IV fluids, no, because she's taking oral fluids. So what do you do in the assessment part? All parameters going smoothly. There is no alert responses. So what do you plan for her?
watch for spontaneous progression.
When do you do a next vaginal examination? When do you, what are the other assessment? How often you'll do the other assessment? Every hourly?
Every 4 hours.
4 hours.
Every hourly assessments like supportive cares and other things, except baby heartbeat, we every 30 minutes. Otherwise, everything is like a contraction every 30 minutes. Whenever you are seeing the baby's heartbeat, contractions and duration of contraction. Rest of the things, hourly management. When do you do a vaginal examination?
Every 4th hour, ma'am.
4th
Huh?
hourly.
4th hourly.
4th hour.
Okay, so after 4 hours, so it's 4 p.m. So 8 p.m. only we'll be doing the next assessment. Correct?
Yes, ma'am.
Okay, since then you will be doing other monitoring. So exactly 8 p.m. She has been done. No, within 2 p.m. 6 p.m. she has been re-examined. Why? What could be the reason why they have done a 6 p.m.?
No contractions.
She asked for the baby probably
Pain.
management. Okay. So she is reassessed. Head is 1/5. Vaginal examination 9 centimeters. Rupture of membranes.
Membranes.
Yes, rupture of membranes clear. Like a vertex at 0 stations. No caput, no molding. Position is anterior. Now everything has been written. Only thing is the posture. She is in the supine posture. That is only red mark. Red mark. Okay. So rest of the things is fine. Okay. So what do you do for this? Pain management has been given, Internox has been given. So what's the plan? Is she progressing?
Continue. Yes,
Yeah.
ma'am.
Is she progressing well? Continue. Will you do Synto? Oxytocin?
No, ma'am.
No, ma'am.
Okay. So is she having hypercontracting?
No, ma'am.
Adequate contractions.
It's less than 5.
5 and less is like still within the normal limit. And durations 45 seconds is more than 60 seconds only. Tonic contraction is that. So duration is the contraction lasting more than 60 seconds only. We will be alert. Otherwise, still it is normal. Okay. So continue the progress and 8:30 she delivered. Okay. So we'll move on to the next acute bradycardia. So we'll go with the case. Okay. So someone Arudra or Shafrin. The case A.
Ma'am.
Case A, ma. Can you, this is 38 weeks spontaneous labor, vaginal examination, cervix well effaced, 2 centimeter dilated, mid position, soft, vertex at -2 station, bag of membrane seen. Can you read the CTG?
Yes, ma'am. There is no first we have to go according to that Dr. C. Bravado. For that, there is no definitive defining risk factors for this patient. Then contractions. The patient having a hypertonicity. Then baseline heart rate. We can't determine the baseline heart rate here, ma'am.
Why baseline heart rate could not be determined here?
Because to determine the baseline heart rate, it should be between two acceleration. There is a straight line between two acceleration, or there is the straight line between the two contraction. Either one should be present. We so we can't.
At least you
tell-
needed 2 minutes. Okay, here the
Yes,
2 minutes,
ma'am, 2 minutes.
two big boxes we needed it. Okay, so
Okay,
here
ma'am.
it is not able to do it. That is nowhere. It is only one box, only 1 minute
Yes,
we
ma'am.
have. So that is the reason. Okay, very good. So baseline heart rate is indeterminate. Then
Um, Variability. It's around 5 beats. 5 to 8 beats இருக்கு ma'am. 5 to 8 beats ma'am. Then acceleration, there is no obvious acceleration here ma'am.
why can't this is an acceleration? See, this is not an acceleration.
To define the acceleration, it should start from the baseline and 15 beats. It should rise and come back to the baseline again ma'am.
Very good. So it is correlate with the contraction. It is like misnormally taken as an acceleration, but it is not actual acceleration.
Acceleration.
Okay, great. Okay. So there is no accelerations. Variability
Acceleration.
is
And the CTG is showing deceleration. It's for more than 10 minutes. It's longing for more than 10 minutes, and it goes up to 60 beats per minute, ma'am.
okay.
And variability is also reduced within the CTG. I mean, within the deceleration. It shows like prolonged deceleration, ma'am.
So what could be the reason for this deceleration?
Maybe due to the hypertonicity.
Yeah, so here the hypertonicity means this is what the hypertonicity we meaning there is like a irritable strong contractions. The contraction is not coming into the baseline. Okay, what is the duration of the contraction? Each contraction we are talking about the LCG, the durations. This is from starting to the contraction to the end. This is
Yes, ma'am.
okay. This is the duration of the
Duration of contractions.
contraction. This is if it is more too large square, that means 60 seconds, then we will be coming as an alert. Here the duration is more, as well as the tone is also, it stays in a higher intensity. That is why it is called. So in what condition you have this hypertonic uterus?
Hypertonicity.
The uterus is not relaxing in between the contraction, it's on the hypertone, and with the fetal heart rate is deceleration. So what condition?
It may be due to abruption.
Great. Okay. It is because of the abruption. So you have to do your drills, prepare your team. Okay. So Shafrin, can you read the second CTG?
Ma'am, this is primary 40 weeks induction of labor with epidural analgesia as pain relief. Vaginal examination, cervix is well effaced, 3 centimeters dilated, bag of membranes plus. So the risk factor for this patient is induction of labor and epidural analgesia, ma'am.
Okay, so correct. So DR is like 40 weeker, induction of labor, epidural. Very good. Then contraction?
Contractions is like the patient is having 2 contractions in 10 minutes, ma'am.
Okay. Only one contraction I can see. The
Okay,
two
ma'am.
were short contractions. Okay, after that, it's all below the baseline. Okay.
Okay. The baseline heart rate is 160 here, ma'am.
Okay. So here you can have a good adequate time period where you know the baseline, we can read the baseline compared to this CTG. Okay. So that is why here it is in the baseline could not be read. Here the baseline is 160 beats per minute. Is it normal or not?
For a 40 weeks like primary 160 may not be taken as a normal baseline heart rate, ma'am, because sympathetic development would have had happened after term.
Parasympathetic. Okay, parasympathetic has been matured. So still a catecholamine surge is there. That means sympathetic is more. Okay. So we cannot consider this as a normal. So baseline is, you have a suspicious category of this baseline. Now, what about the variability?
5 to 10 beats per minute variability is there, ma'am.
Okay. It's normal?
Ma'am?
It's normal. Is it normal?
Yes, ma'am.
Okay.
5 to
Then
25 beats per minute lasting is normal variability, ma'am.
okay.
There is no obvious acceleration seen, ma'am.
Okay.
Deceleration, there is a deceleration like for more than 3 minutes,
Okay. Okay.
reaching up to 60 beats per minute. 60 beats, ma'am.
60 beats
Uh,
and stayed for 2.5 minutes. Okay.
and
And then,
it is reaching back to the baseline.
okay, it's recovering and
Recovery.
coming to the baseline, stay back at the same 160 beats per minute. So what could be the reason for this? There is no contraction, no contraction is noted. What could be the reason for this?
Because of epidural analgesia, vasodilatation and pooling of blood in maternal blood, and hypertension for the baby.
So hypotension. Okay, it's because of the epidural induced maternal hypotension which is causing this bradycardia, this prolonged decelerations. Okay, which is recovered once you have taken care of. But on this whole, will you continue the CTGs or what do you do? So we will be continuing the CTGs because you are not happy with the baseline heart rate. Okay, it's suspicious. Fine. So whenever you have an acute prolonged bradycardias, as soon as you see the bradycardias, when do you act? What do you do?
We'll see the fetal reserve.
Okay. So first of all, you have to see the fetal reserve. Before that, there are three things we have to rule out. What are the three things? Almost complete
Irreversible
eruption.
causes, uterine rupture and cord prolapse.
Okay, so placental abruption, which is our case, the first case, then uterine rupture and cord prolapse. In those cases, we won't be seeing all the reserve and other things. We'll be directly do a PV and directly move the patient into the theater. So it is all irreversible causes. Okay, so reversible causes only you will be seeing your assessment, reserve of the baby, whether the reserve of the baby is correct or not. Okay, so irreversible, there is no rule of three. What is rule of three?
We have to uh, escalate to the seniors within 3 minutes and make decision within next 6 minutes. And
start intrauterine resuscitation in the 3 minutes.
um,
Look for the recovery of the baby, which happens. Most of the babies will recover within 9 minutes. Okay. Okay. So those things cannot be done for irreversible causes like abruption, rupture, cord prolapse. We directly move into the theater. Only for the reversible causes, the rule of three applies. Okay. So irreversible is this. There is hyperstimulation, hypertonic, persistent prolonged. Reversible is most likely this kind because of epidural or change of maternal positions. Fine. Okay, so when do you call your teams? At 2 minutes or 3 minutes of deceleration? When do you call for help?
but then if it is
Prolonged
the deceleration prolonged for 2 minutes,
more than
2 minutes.
More than at the 3rd minutes, your help should arrive. So when you see a deceleration of 80 beats per minute for 2 minutes, you have to do a resuscitation. What resuscitation you'll do immediately?
changing the position,
Changing the position.
IV
fluids.
resuscitation.
Stop the
IV
oxytocins and IV fluids.
IV
Okay.
fluids.
Okay. So that's more important. So looking for the causes, how will you diagnose your abrupture, cord prolapse, and uterine rupture?
Perabdominal examination
with vaginal examination and vitals
monitoring.
Okay. How do you diagnose rupture?
Fetal parts will be
palpable perabdomen with tendon.
presenting part being lost in the vaginal examination.
Very good. So when you do a vaginal examination, the presenting part, as soon as you have a deceleration, the first thing you will be doing a quick vital examination, check the abdominal examinations, whether is there any hypertonic contractions, if the fetal parts is seen or not, and then do a vaginal examination, look for rule out cord prolapse, look for the progress of the labor, look for the vaginal bleeding, and there is a loss of presenting part is a sign where it is could be because of the rupture. Okay. So that's how we will be doing a vaginal examination as well as the maternal vitals. How will you check the fetal reserve? So you said fetal reserves. Okay, how will you check the fetal reserve? This baby, these decelerations will recover. This deceleration won't recover. After ruling out your abruptions, cord prolapse, and then uterine rupture.
So we check.
We have to see the deceleration. Before the deceleration starts, we have to see the baseline heart rate, how it is.
Okay.
And variability within the first 3 minutes of the deceleration, and depth of the deceleration with how long the deceleration is.
Yeah, three things. So you will be seeing, is there any kind of fetal heart rate tachycardia? Second is like variability before the deceleration and during the decelerations, and the depth, how many beats it's going. So any things like more than 80 beats down and lasting more than 3 minutes have a poor prognosis compared to with loss of variability or previous variability. Compared to this. Shafrin, can you read this CTG?
Yes, ma'am.
Mm.
Here, we can't tell about the definite risk and the contraction. There is no obvious contractions.
Mild
And
irritable contractions.
by irritability only, ma'am. Then the baseline is around 180. Sorry, 130, ma'am. 140. Yes, ma'am. 140. Then the deceleration is it's around.
You said variability. You said
variable.
fetal
ma'am.
reserve, you say that there is a fetal tachycardia, less variability. Okay. So here the variability?
Variability is
more than 10 beats.
Then
More than 10.
Are you happy?
It's no, ma'am. It's 5 to 8.
Okay.
Yes.
Hey, 5 to 8. 5 to 25, it's normal, man.
Yes, ma'am.
Okay, so
Here,
you have good variability, right?
yes, ma'am.
Okay, so decelerations?
Within the deceleration, the variability is reduced
Okay.
compared to the before deceleration, baseline variability. And it's again picking back to the
depth of decelerations from
it's up to
140 it has gone up to 80.
80
Okay. And then it started coming up.
coming
So
back.
compared to the this side, and which one are you happy and why? What are the positive in this Shafrin? Whatever you discuss, what are the positive things you will be concerned about this, and what are the negative about this?
There is no tachycardia in the CTG where I read, ma'am.
Yes.
And that either variability is not that much reduced compared to the first one.
Okay.
Within first 3 minutes of the deceleration, and it again picking back to the baseline, ma'am.
Okay, so this is, though it is an acute bradycardia, it could be because of supine hypotension or reversible causes. Okay, the baby have very good reserve. So once your resuscitation are done, your position change, IV fluid stop. If there is an oxytocin, you can stop. If for hyperstimulation, you will give a tocolytics. Okay. Okay. So the first 3 minutes of deceleration is mainly the variability. So how is here?
Variability is more than 10 beats, ma'am.
Okay.
Variability is good, ma'am.
Which one is we will be like worried? This one or this one?
First one is we need to worry, ma'am.
Why?
Prolonged. It's prolonged deceleration, and it doesn't come back to the normal
It's
baseline, and it's
an abrupt fall and stays for the longer time in this.
longer time. Yes, ma'am.
That is more important. Okay. So the depth is more important. So compare these two things. So will you concern about this one or this one? And say why? Which is
First
the
one, ma'am.
First one is will be concerned, and second one?
Second one,
The variability and heart rate is normal. The previous CTGs, that is previous 10 minutes, what happened is more important in acute bradycardia. Previous 10 minutes, if that is fetal heart rate is normal, variability is fine, and during the decelerating arm, the variability is fine, then this could be resuscitated and come back to the normal, unless otherwise there is no irreversible causes. Okay.
yes, ma'am.
Fine. Okay. And compared to these two things, so what could be the reason for prolonged deceleration here? Here you said it's abruption. What could be the reason for the this one?
Hyperstimulation.
Hyperstimulation. So how many contraction? 1, 2, 3, 4.
Hyperstimulation.
Okay. So what do you do?
We have to look whether the oxytocin stop. If we start that, we need to stop the oxytocin.
We can give tocolytics.
Yeah. So after stopping stopping in side by side, you have to start tocolytics. Which tocolytics will you give?
Terbutalin.
Dose?
0.25 mg.
0.25 mg subcutaneous.
Subcutaneous.
Subcutaneous. Okay, very good. Okay, so these are the most important things. So when the deceleration comes side by side, call and look for the CTGs for the what are the good reserve fetus, what is the bad reserve fetus. Okay, so now after that, when you doing a resuscitation, see the current fetal status and see the signs of recovery. So what signs of recovery will be better recovery? So compared to this, Arudra.
In the first CTG, the deceleration is picking up to the baseline, ma'am.
Okay. It's coming to the baseline. Second CTGs. It is also picking up. It is also picking up. But why you are concerned about the second CTG?
It is going cardiac, ma'am. It is.
So it is
compensate. It could be a compensatory tachycardia following the bradycardia, ma'am.
Okay, so it is going in for the tachy. So you will be more concerned. It is not coming into the baseline normal rate. So this baby is like a poor reserve. This baby is, even though it is a reversible causes, this baby has to be delivered immediately compared to this. This could be maybe because of the hyperstimulations. If you control the hyperstimulation by intrapartum resuscitation of the fetus, the baby has come back to the normal with a good reserve. Okay, fine. So this is how you have to make the decision. You have to rule out the irreversible causes, look for quick examination, find out the cause. And once coming into these categories, reversibles, look for the reserve. Before the decelerations, you have to look for the baseline fetal heart rate variability. During the first 3 minutes of decelerations, depth of deceleration as well as the variability. So another point to add to be here is the depth of deceleration. Then during the recovery phase, variability, signs of recovery, we have to see. So irreversibles, there is no rule of 3. Okay, so how do you do intrapartum resuscitation? You have already discussed. Okay, so we'll move on to that. Okay, so tocolytics, terbutalin, make it available in all your unit. That is That is the most important. It should be available in all the delivering unit. These are the other tocolytics may not be as good as tocolytics, terbutaline. Fine. Okay, so if it is improving, observe. If there is no improvement even after intrapartum resuscitation, or if it is going in for a compensated tachycardia and not coming to the baseline, no signs of recovery, then also you deliver. So this is how. So this is the final diagram. So when there is a deceleration occurs, that first 3 minutes you have to include all your team, start resuscitating, call for help, rule out all your 3 causes of irreversible causes of decelerations, and next 6 minutes you have to make an actions to move on to the theater teams, anesthetist to be ready, in NICU team has to be ready, and 9 minutes 95% of babies has to be recovered by 9 minutes. CTG has to be recovered. So if not by 9 minutes, it cannot be recovered. So 12 minutes the patient should be delivered by immediate delivery, and 15 minutes baby has to be delivered. This is a 3 minutes rule. So what are the things you will be look for if it is recovering? Then you have to continue the CTG, whether it is coming into the baseline or is going for tachycardia or it is going for another deceleration. So you have to look for the clinical picture, stage of the labor. In the previous CTGs, the previous 3 minutes, what are the things you will be looking for the previous 3 minutes? Quickly tell me.
Baseline heart rate, variability, depth and duration of the deceleration.
Super. That is why that will tell you whether this trace will pick up or it will go in for the decelerations. Okay, it will continuous decelerations or it will go to pick up the previous CTGs, and during the first 3 minutes of CTG will tell us. So this is for your 3 minutes rule. First 3 minutes, call for GLEP, immediate clinical examination to exclude irreversible causes, placental abruption, umbilical cord, uterine rupture, and correct potentially reversible causes during the first 3 minutes. 6 minutes, intrauterine resuscitation, continue to improve the oxygenation by giving a tocolytis within 2.5 minutes. Your baby will be completely recovered, come back to the baseline. So 90% of prolonged deceleration are expected to return to normal baseline in the absence of irreversible causes. 9 minutes, 95% will be return back to normal. If not, 12th minute, you have to assess the overall clinical context in the operation theatre, including the assessment of FHR to confirm recovery. If an urgent birth was required on the basis of assessment, then administer anesthesia. Go ahead with emergency operative vaginal delivery. Okay. So, thank you. So, any questions? Any questions?
Deepa ma'am, basic question. When
Ah.
to shift to theatre in this 3 minute, 6 minute rule?
6th minute, you have to start shifting the patients. By the time 6 to 9 minutes, start shifting the patient. 12th minute, the assessment should be in theatre.
Okay.
Okay. Okay.
Jayashree ma'am is there, huh? Madam?
Ma'am
Yes,
is there.
yeah.
Ma'am, closing comments if you want to give something.
We have
I think
exact
all the
9 minutes.
three of
Excellent.
them did very well. Congratulations. And I'm happy to see that this interpretation of CTG is evolving from the time we started. Very happy to see everybody with it. So every single CTG you see, just think of Deepa and just stick to the Dr. C. Bravado. Automatically you will interpret it.
Especially today's session is of acute bradycardia, is you have to act immediately.
Yeah.
Okay, so this is, you have to do the drilling as and when needed. Whenever, even there is no bradycardia, so you just mimic that it is in bradycardia, keep your things ready and move to the theaters. Rehearsal has to be done in the hospital. It's like a shoulder dystocia. You have to do the drillings. It's like a maternal call, like a med call for the fetus. Okay, your hospital has to support. Thank you, ma'am. Thank you, Aditya.
Thank you, Deepa,
Shafrin,
Priya,
Pavna, Nandini, and Priya.
and I think thank you, Pavana,
Thank
Arudra, and
you.
Shafrin for taking part.
Thank you, ma'am.
Thank you,
Thank you
ma'am.
for this opportunity, ma'am.
Yeah, I have to thank Sampath madam and our secretary Meena. Thank you, Meena.
Thank you, madam. Thank you, Jayashree ma'am.
Thank you,
Deepa
thank you.
ma'am.
Meena is in the car, so you don't want to switch on your video.
இல்ல மேடம். At home only, madam.
Right.
Okay. Yeah. Always
Thank you,
busy,
ma'am.
Madam Meena.
இல்ல மேடம். வெட்டியா வீட்ல தான் இருக்கேன்.
Thank you. Thank you.
Very
We
good.
close the
Okay,
So
session.
bye.
before
Thank
you
you,
all
ma'am.
leave,
Thank
kindly join us again at 7:30
Yeah,
for
7:30,
the
please.
clinical research hour.
Yeah, today is
Yeah.
it's a you are from an obstetrics you are moving into the dry subject which is going to be make it easier by the Priya as well as the pediatric endocrinologist Dr. Hemchand. Okay, so please do attend. That is going to be interesting cases. Thank
Yeah,
you.
join after half an hour. Thank
Yeah,
you.
please join. Yeah.
Thank you, Jayashree ma'am, Deepa ma'am,
Thank
Priya,
you.
and all the
Chitra
dear
and
students.
Priya. Thank you.
Thank you.
Bye.
Bye, madam. Thank you, Sri Events, for the platform.
Thank you, ma'am. So we can end this meeting. I think we have to log in another different platform than the same meeting. Are we going to continue? So Sri Events, can we end this meeting, Pa?